I would like to welcome Stephen Collman, who's the MD of the Worcestershire Acute Hospital Trust, and we've asked him here today to talk to us about the outcome of the last CQC inspection of the ED department at Worcester Royal. It resulted in a requires improvement rating, and we would also asked him to talk about the action plan and anything that they're doing to respond to the CQC. Good morning, Stephen.
So probably what I'll be able to do as well is wrap up a kind of where we've been at winter as well, and kind of much of the action we're taking in response to the CQC is applied through anyway, and probably give an overview or assessment of what we've got to do, where we've been, because I think it's fair to say urgent emergency care has been a particular tricky issue for the trust over a number of years. It's a bit variable and it kind of does well for a period, then it drops off, so it's not sustainable. It hasn't been sustainable, some of the improvements. Fundamentally, the issue that we're dealing with in the emergency departments, both at the Alexandra and at Worcester Royal, is around overcrowding and how we best manage that. And fundamental to that, the biggest thing that we can sort out is around patient flow. So if you arrive at the department, how fast we can move you through it, but also if you need a bed, how fast we can move you into the right area. And that you can tell when that is, we're not alone in this, but there's been recent reports as well into things like corridor care from the RCM, Royal College of Emergency Medicine. They've said quite a bit about it. We're not alone in using those spaces, but they're not ideal. And I would want to say to you, our commitment is absolutely to try and eradicate that. That's when we know we're getting it better. So the point in time at which the CQC came was a busy period, as ED has been throughout the year, and the last particular winter has been exceptionally busy. If I highlight, we've been doing a lot of kind of work and analysis as we do anyway, and one of the indications that we're getting, particularly for the Worcester Royal site, is quite a significant increase in attendance over this year. So this year has been a particularly tricky one, and I'll link that to, there's kind of three themes really that we're looking at to improve. I've had a number of conversations with Simon and probably some of you, and I've been at HOSP before. One of the things that I do want to give an assurance around is the patient experience we know is not right, and we would apologise for that unreservedly kind of at the minute, particularly when it's pressured. And some of the reason that I stress that is when you see the CQC and some of the areas that they've said that need improvement, which we recognise, is a result of that overcrowding. It's too busy. So this isn't that staff don't want to do a good job. We've got to find a way of kind of making the job doable, and that means they can deliver the care that they really want to deliver. And we want people to experience when they come to our EDs. And also widening, a really important thing that we've been trying to tackle this year is we've also had, and there's been a lot of media around that you'll have seen, protracted ambulance waits as well. So we're really trying to take the view of, it's not just the minute you hit the front door or you're in, this is a community issue as well, and we've got to resolve people being able to access either through walk-in or through the ambulance a really quick response. So I can touch on some of the things we're doing around that. So the three things that we kind of think through are, if I can put it, is one is demand, one is the level of occupancy in the hospital, and there's two main things that we're concentrating on trying to improve there. And then third is what we actually have to do in the emergency departments, both of them, to make sure that we can process as fast as possible. And that's really central to the action plan to the CQC, because what I'm trying to do with the teams, and Sarah is as well, who's the lead for it, is it's really, what I want to avoid is just answering specific points, but missing the underlying theme and the underlying driver of that. Because I think sometimes you try and avoid hitting the target, missing the point. Sorry, the bit I was going to say as an assurance as well, I've had this conversation with Simon, is one of the things that we're absolutely, we drive quite hard is, again, not having performance targets. that then drive the wrong kind of outcome. So if you look at some of the performance targets that we have around A&E, such as the 4-hour standard, targets around ambulance offload, we really take the view, if it's working right, you hit those targets by default. What you don't do is kind of drive the wrong thing by just focusing in on one thing and saying you'll kind of really push at that. So I just want to kind of give that assurance. Our overwhelming thing is decompress ED, get it flowing properly. Everything else will follow from that. Colleagues will be like really happy working there. Patients will have a brilliant experience, and we'll hit the targets by default, not just focus on that one thing. That I just want to kind of give that assurance. That's what's underneath this. So if I talk about demand, one of the things that we're working really hard with the system partners is, so that's both the ICB, West Midlands Ambulance Service, Health and Care Trust, ourselves and primary care, is around trying to get patients into the right area as fast as possible. So we've got what we call a single point of access. So if you've got a healthcare professional that's not sure about what you need, we've got ACPs, as we call them, so advanced care practitioners, that you can ring into. They'll triage it, give you advice. What we are starting to see is they are triaging and pushing more people towards our same-day emergency care. So rather than go to ED, they'll book you in and say, you can go to our same-day emergency care. And with the primary care hubs that the ICB have developed, there's more enabling into that as well. So people are getting better access to same-day primary care through those. So we're building on that. The other bit we're working really closely with West Midlands Ambulance Service with is, if a crew attend and they've got a patient, they're ringing into the single point of access as well. So it's what we call before convey. So they will ring in and try and avoid bringing the person to hospital if they can avoid it. So that links into community services as well, who can respond and do various things. The other bit we've been trialling, you might have come across it if you've been to the Worcester Royal site. And fundamentally, this isn't ignoring the Alex, but this is the way that the service has been constructed. Worcester Royal demands and is such a hot site that's the one. If we resolve that better, we have a significant impact on urgent and emergency care across the county. And one of the habits, and I can understand why the trust has got into a little bit, is if Worcester Royal is too hot, they divert to the Alex. So that has a consequential impact then on the Alexandra. Whereas actually, if the Alex can manage its own thing, it tends to do really well. So we've got to kind of one of the fundamentals under it is resolving the Worcester Royal issue. But we've been piloting for about 3 weeks now, something that we call the pit stop. You can't avoid the names, and it's not a Formula One thing where the ambulance drives in and gets its tyres changed. What happens is it pulls up outside our same-day emergency care area that you'll know is the old A&E. And in there, we've got cardiology, surgical and medical same-day emergency care. So what we've been piloting is, as the ambulance comes in, unless it's an alert, so stroke, cardiac arrest or anything resus needed, it will pull in, an ACP goes straight out and assesses, does a 5-minute assessment. And what we're starting to see is they're pulling more straight into the same-day emergency care. So they're avoiding A&E altogether, which is meaning what we're starting to see in terms of our ambulance performance and in A&E is it's starting to have a bit of an impact, and it's becoming more manageable in there. And people are getting to the right place, right time, a lot quicker. So that's showing some signs of hope really for us, but it's early days and I would never want to overpromise. But we're running that 10 till 6. Because one of the things that we see, particularly here is at the Royal, is mid-afternoon we start to build, and that congestion just then carries on through the night, and that is what particularly causes protracted ambulance delays and an overcrowded department. It's the build of it, it's the cumulative effect rather than kind of rapid and sudden influx of people into the department. You occasionally get that, but that's generally what we're doing. So if I move to occupancy, overall, we're currently running about 110% occupancy, which is far too hot. We're probably one of the hottest trusts in the region, if you like, for how occupied we are. Now, that's not to say and that is not a criticism in any of this, because I know there's been a bit of history in that with the trust. We're working exceptionally close with the ICB and the Health and Care Trust about how we can decompress. And a lot of it is on us to do. We've got a lot to do ourselves before we start kind of looking at other people, but we've got some things that we've got in train. The two biggest kind of factors in our occupancy are what we would call either general medical patients or frail patients, which will not be a surprise to you. You'll all be sat there going, well, that's barn door bleeding obvious. We could have told you that, and we probably have told you that for years. But we're really, like, we've been quite heavily trying to invest in both general medicine and frailty over the last year. And the other one is trauma. And again, that will not be a surprise to you with a population that is growing over 75, over 60, over 75, and that, with patients who potentially fall, fractured neck of femur, or falls in other areas. That's the other group that we're really trying to focus in on. And I think, so now we're starting to see shoots that the general medicine frailty one is improving. Trauma is a real focus for us about how we kind of better give people a better experience of that. That's another area where it's not just right at the minute. So to do that, we've created more specific general medicine wards. We've invested in the team. We're investing in the medical staff. We're recruiting quite heavily in that. And to kind of put it into context, for general medical patients, that includes frailty, they're disproportionately, they're 20% of what comes through the door, but they're about 60% of our bed base. They're disproportionate in that. So some of the things that we're looking at is, one, building up our frailty same-day emergency care, our frailty assessment unit, so that if we can turn people around quicker, they don't have those long lengths of stay. The other is we're working with the community trust around a couple of pilots, and some of this has been done before, so we're revisiting bits, but some of it is slightly new. We've called it like community gen med. So what we're looking at is patients who've had either fractured neck of femur or our general medical. Can we move them towards their local community hospital a lot quicker on their journey? So we're asking ourselves the question, what do they need in an acute hospital? What are we providing here that they couldn't have at, for example, the two wards we're piloting on at Malvern and at Princess of Wales? And actually, a lot of that is skill and medical oversight. So we're trying to do a partnership with the Health and Care Trust where our doctors will outreach to their wards, and we help and work with them. And then we get patients out around, we call it like day 5. And it's starting to show some promising results, particularly for fractured neck of femur patients. Because effectively, once they've had their surgery, it's not an orthopedic issue, it's a frailty one in their recovery. And we're starting to see, it's very few patients at the minute that we're doing it with, but some of the indications are we're actually getting people back home or with less care needs a lot faster. And that really builds on the community hospitals as a resource. So rather than get into this, I've got too many of this, too many of that, that's a real asset and a real sense that people will be close to home as well. So that's one that we'll keep you posted on and keep you there, but it's a really good early sign on that one. And then finally, I've talked about internal processing. So one of the things that we're keen to do is to look at, have we got the right workforce in ED? Have we got enough senior decision makers at the right time of day to mean that people can have kind of their diagnostics, a senior medic look at them and say this is where they need to be? Because again, the evidence is if you wait too long for that, we all know, particularly again, older people, things decompensate, it's a worse experience, it's that kind of thing. And we've got more chance of people being able to get back home or back into their nursing care home, which is their usual residence, which is better for them than a protracted wait in ED. So they're kind of the three really big things that we're kind of tackling that I think fundamentally change the nature of urgent and emergency care within the hospital. There's obviously lots of other bits we are doing, and that's very much focused on adults. We are trying to have, we're doing quite a bit of work around the site at Worcester Royal and at the Alex of what's on what site and what can be done differently. So one of the bits we're really keen to progress is for women's and children's is a paediatric assessment unit, which again helps children's flow in ED, because if you're in ED and you might need a bit more time just to check what's going on, what's happening, a paediatric assessment unit can be really helpful in that, because it's not a crowded department. You move them out, can be looked at, they do various tests and things, and again it's a much better experience for children than either being in ED or getting admitted to Riverbank. So we're looking at how we can deliver that on this site. This site is really constrained, but fundamentally we want to resolve that one. And there's similar issues as well around, you'll have been heavily involved in the stroke conversations and consultation that's going on now. Stroke is another one. But driving all of it is a principle of we don't want to be expanding acute any more than we need. We need the community pathways to be working, and we've got a responsibility to help that with our really senior medical staff who are experts in this as well. So that's about us working really closely with community partners. So I think I've talked long enough. I'm more than happy to take it. I don't know if that helps, Joe. I don't know if that's what you have to put that. That's rather than get into specifics of the app. I think they're the big three things that we're kind of really aiming at to put urgent care on a much better footing, much better patient experience, and much more sustainable in what we're trying to do.
Yeah. Thank you, Stephen. That was really interesting. Can I just ask one question? The same day emergency care units, do you have enough? Is there enough capacity in those to take up? Do you end up just queuing in a different place, or does that work?
You do wait, but actually what we're seeing is the wait is not as long as it would be in ED. So that's better. And also the other thing because we track it quite heavily, like we watch it a lot to make sure we're not creating queue in another area or we're putting too much risk into it. And actually what we're seeing is that evidence that we are turning around patients in a day. So you may be in there for a few hours or like a few hours. But what we track heavily is the number that need a bed at the end of the day. And actually, it's not necessarily a bad thing if you do need a bed, because what that shows is that what we're trying to do is we try and give it the best chance of turning you around. But there are still some patients when you do that you end up going, no, we need to get you in now. But it's a lot safer environment than it is in ED. So we do watch that one, Joe. There have been a couple of times where the capacity has been kind of full, and that's one of the reasons we've moved it and we've got it in the old ED, because there's actually quite a lot of space. And the other thing was because we put them all together where they were separate before, so a medical one was in one part of the building, surgical in the other, it means we can flex it a bit. So if we've had more medical patients arrive, we can flex a bit into the surgical space. Equally, we can go back the other way. And the other thing, which is an unintended consequence, but is actually interesting that staff are telling us, is you quite often get patients who aren't one or the other. They present a bit of both. And actually what started to happen is the staff are just talking to each other a lot more, and it's really creating an environment where they're cross-working on the person who's there, rather than, right, we now have to refer you over there, or you have to wait because we've referred you to that as well, or we're not sure what's going on. So we're watching it really, really closely, but the signs are encouraging. It may be, it is one area that we may have time, probably not this year, next year, probably have to think about expanding it, because more and more will go through it.
Yeah. Thanks very much. Does anybody have any questions? Can I have the directors first? I can't actually see hands. That's the only problem, I don't think.
I've got a question, Joe.
Oh, thanks, Debbie.
Okay. Hi, Stephen. I'm Debbie. I'm one of the directors and I'm the lead for children and young people. I've got a question around in the report, it stated that between May 23 and 24, under 25% of 534 patients with learning disabilities had been seen by the learning disability team. So effectively, that means 75% had not. What are the plans going forward to change that? And also, with regard to the mandatory learning disability and autism training, slightly Oliver McGowan training. A member of the public had sent me a recent Freedom of Information Act request, and it's shown as that September only 17.8% of emergency department staff have completed Tier 1. Now, obviously, Tier 1 is very, very low level.
Yeah.
Tier 2 is obviously for, you know, clinical staff and that might be dealing with people with learning disability and autism. So what are the plans for those?
Okay, so take the first one. One of the bits we're keen to do is look at how we can expand. One is the learning disabilities team. Second one, slides go all over, I can't see now, baby. Wait, I'm told someone can't see. I'm sorry, I got distracted a bit there. So one is about how we look to expand the learning disability, not just for ED, but across the hospital, and how we respond to those needs. The other bit, and this I say this from my background with mental health and learning disabilities when I set up liaison services, one of the other bits I think we can get better at explaining is those teams are brilliant at educating the staff, so it might not be you directly need, everybody needs to see the learning disabilities team, but it's the training and the expertise and the kind of consultation they can give to the staff. I do link it back to the other bit. When staff are really, really busy, this is the kind of thing where it starts to slip and it's not quite as you'd want it to be. So fundamentally, I've got to give the staff in ED the time and the headspace and the environment that they can really think this stuff through and really make it meaningful. And that's on us as execs and the other to make that work for them. And that, because I really want to get across, I don't think that's staff don't see it as important. It's just when you're busy and you'll have been in the department, when you see it as it is, they are just literally running around doing all of that stuff. And I think we have to look after colleagues in that, because actually doing that day in, day out can be really wearing, and the kind of whole caring and compassion bit. If you're in that environment constantly, the evidence is it starts to wear down a bit. It's not that they don't, then they've all come into that. But, you know what I mean? I want to really emphasise that.
Yeah.
I've got to be really, I'm really clear with us as and the exec team about what's our job to solve and what we've got to do. In terms of the Oliver McGowan training, we've been really putting a big push on that. I don't know the exact figures for ED, I can let you know, but we've been doing that across the trust. And we've really kind of been pushing that. So I'll get the up-to-date figures. I will be fairly confident it's a lot higher than it was when that was pulled.
Okay, thank you.
Hi, Stephen Byrne here. I am one of the directors of Healthwatch. We've had a couple of reports come through about the use of do not attempt cardiopulmonary resuscitation. So we could do with some reassurance, I think, on this, probably outside of this meeting on that process. So, for example, some patients may well have a DNA CPR in place, but they come in with a different issue, and it needs to be sort of reassessed, really, you know, depending on the needs of the patient. So some patients may have a DNA CPR in place, but they may still wish to have intubation or surgery. Like I said, we've had a couple of sort of reports through where patients have automatically, you know, been assessed in terms of their previous respect forms and everything, rather than the current needs of them when they come into the hospital. So assumptions, I guess, is what we're hearing.
Yeah, just do a bit on that, and we will come back to you, Chris, more detail. But if I can just give you some assurance, I was made aware. So I had a call between Christmas and New Year with Simon, where I think this was starting to be raised. So what we've done, Sarah and Jules. So Sarah's our chief nursing officer. Jules is now our substantive chief medical officer. One is immediate communication out to all staff, nursing and medical, and they're putting quite a robust audit program around it as well. So not only are we making sure we're communicating that at all angles, but I want some evidence, and I want to check it and do that. But we did that immediately following that call once we got that feedback. So we're more than happy to do more detail on it. But I just wanted to say we've not hung around. We've kind of got on and when I've heard that.
Okay, thank you. Thank you.
Thank you very much. I was just going to ask you a question. It might be slightly unfair to ask you because it's you were talking about the primary care hubs, and I'm not sure that the people at the meeting would actually necessarily know what they were or how they fitted in, because it's a fairly, I know they've had the previously over winter, but sort of how do they work? And if you're a member of the public, how do you access them rather than going to?
I'm not exactly sure on the mechanics of how we access them. I do think it is through your GP. I do know because we. Although we're not connected as such, I do know a little bit about them, and I think it's to be really clear. So these aren't an alternative to A&E or other things like that. But there is clear evidence that if you can increase same-day access to primary care, that potentially could have a knock-on to us in urgent and emergency care, but also is again is a better patient experience, leads to better outcomes because you're getting that intervention quicker. So my understanding is they're around the county. I don't think every practice. I think practices link into them, and it's just to drive up that access to primary care on the same day. And I think there's good usage of it. I think you get signposted to it if you go through your practice. So that's the kind of model that it's running. But where we're interested in some of the data we've been running is what you can. There is an evidence base that says if you've got particular areas that have relatively high deprivation and are close to an A&E department, people will disproportionately use it for relatively low acuity, urgent primary care needs. We're running the data on that to see, because obviously both our hospitals, particularly at Redditch actually, are around those areas that will be identified as higher deprivation. So we're just doing a bit of work to see if that holds true. But the more access people get, and the easier the access is to primary care, it could have an impact on that.
Thanks very much. And I think we have a question from a member of the public. Is that, was it Melanie D? Sorry, check my chat. Yeah.
Hi, yeah, thanks, Joe. I'm Melanie Dawson and I manage a nursing home, but I also chair the Worcestershire Registered Managers Group, and I'm the chair of the ICB Social Care Faculty Group as well. My question is around the respect forms. One of the things that we've highlighted to the team is that the respect forms that are coming out into social care and into nursing homes and care homes are of extremely poor quality. They don't actually, on many occasions, have any details of a person's wishes. These appear to be fairly generically completed with examples of a person's wishes being ward-based care, not for escalation, not for readmission to acute. Now, for me, that tells me that that's a clinician's decision, and it's not really a person's decision. So actually, the fundamentals of respect forms are that it's an individual's plan that should be discussed with them. And if they're not capable of discussing that, that has to be discussed with their relative or their power of attorney. And I think that it's something I've highlighted before, and we were assured that there was going to be some work done, especially with junior doctors at the hospital, around getting these right. But what we've not really seen is that that's improved significantly. And I wonder whether it would be useful to you for us to provide you with some really good examples of these sort of forms that are coming out into social care, because it then adds another layer of work for us at this end.
I would definitely appreciate that. And Melanie, I think with your, I mean, you mentioned a couple of roles that you've got there. I'd be really keen, or get the team to come at me anyway and have that discussion, and then see other avenues that we might explore together. Because I think there's some really important things in there. But on that one, definitely, we really appreciate that.
Yeah, thank you very much. I look forward to hearing from you.
Do you know each other's email addresses and things?
So is there a way that I can get What I can do is, if I go through you, Joe, and drop my email address and others, and then
Yep.
everybody on the call who's got, because there may be other issues that people are doing, but may
Yep.
not want to ask me, I'm always happy to have those kind of chats, really get through them.
Brilliant. Thanks very much, Stephen. Does anybody have any other questions for Stephen? No?
Okay. Can I just, just say, Joe, I don't know if this is the point that I get kicked out, I'll just check that first. if it is, I just want to say I really appreciate the opportunity to come and talk to you about it. If there's any other issues, we'll always come along and talk about it. I really want to encourage, people may not, we're really trying to construct a team here that really welcomes and wants to work with you kind of together on this, because I think we're all after the same thing. I know sometimes people will say that you've been given assurances in the past, as Melanie's just said, but I'm really trying to create a team here that kind of look outward and accept and kind of really want to work with people on changing things internally, you know, so we get the best, because we're all trying to do the same thing. And I just want to kind of leave it with that. And if there's other issues, I'm always happy to come back, or we can have conversations offline.